There we go.
Is the unit test, is that going to be on ATI or is that going to be on Blackboard?
I'm pretty sure it's ATI.
Okay.
Pretty sure it's an ATI format. Okay, so crisis management. What is a crisis? What would you define a crisis as?
Like an acute situation?
Yep, usually happening short term, in the moment kind of thing. So there, and I'm assuming there's silence because nobody can really put their finger on what a crisis is, because in essence, it's what one deems it to be. Don't you agree? Because what I would say is a crisis is something you would say, oh no, this is how I address that, this is how I look at it, and this is how I work with it effectively. So a crisis is usually when an individual encounters or precipitates an event that cannot be dealt with. So say, like, I usually get anxiety for exams. Yes, I do. I usually get anxiety for exams. And so in order to lower my anxiety, I make sure I prepare effectively for the exam, because that is how I deal with my interest level. But if it is that I find that even starting to study early, I still don't feel prepared for this exam, that is my usual coping skill that I usually use to deal with this issue, and it's still not enough, then I can start having disorganization, and I have to reach for like emergency methods of problem solving to continue. Like I'd have to probably go see Pam, go to tutoring or something extra. So it becomes a crisis when one's way of coping, it doesn't work anymore. Usually you can deep breathe or you listen to music, but then here you have a new stressor or something happened that even your regular means and ways of coping through these issues don't work anymore. And that's how you cross into having a crisis. Now, managing a crisis is very, very important, and those are some of the things we will talk about tonight. So we mentioned that a crisis could be from a precipitating event, and that precipitating event could be any stressor that acts upon the individual that threatens either their self-concept, self-esteem, interpersonal relationships. What are some popular stressors that could affect these self-concepts, esteem, or interpersonal relationships?
Like family issues, like a divorce.
Yes, that's a huge one, a very common one. Death of a loved one, loss of like discord in the home between yourself, your husband, yourself, and your kids. So usually anything that threatens yourself, self-concept, self-esteem, you lose your job, you don't know who you are anymore, you don't know where you stand, you were the breadwinner, now you're no longer the breadwinner. So these are issues that can precipitate a crisis. It often requires a solution that is new to the individual's previous level or their previous life experiences. So usually you're using your old coping skills they're not using anymore, they're not working anymore rather, so it requires that you use something new. When a patient is experiencing a crisis, or when anyone is experiencing a crisis, they usually have a temporary state of disequilibrium. And this is shown by anxiety, or it could be depression, disorganized function, or fluctuation in using old and new coping skills. So you have this crisis, you're unable to deal with it, it can present in these ways. So a crisis usually goes through phases. There's the confrontation phase where you're met with the hazard, it threatens your self-concept, self-esteem, you enter into a state of disequilibrium. You're no longer in homeostasis. Your problem-solving techniques, they fail to work. You implement emergency problem-solving techniques, and those fail to work. And this further increases the state of disequilibrium, and you may even fall into panic. It is a major disruptive state. And for someone who has like depression or anxiety, it is very, very difficult for them to work through this state of disruption. Signs and symptoms of a crisis. That'll be a sudden event without time to prepare, feeling overwhelmed or threatened, as we mentioned prior. You have difficulties communicating with others. It could be actual or it could be perceived, like, your boyfriend's cheating, or your husband's cheating, or your wife is cheating, girlfriend's cheating, and you can already sense the loss. Your relationship is falling apart. So while you're not at the divorce state, you can perceive the loss of this loved one, as in you're losing them emotionally. There are different types of crises. It could be maturational, which is a normative developmental crisis that occurs throughout one's life cycle. And this is like if someone struggles with coping with the natural process of development, such as marriage, retirement, usually any life-changing event. They will struggle to work through those feelings. It could be a situational crisis, something that arises from an external event. It's usually unexpected and, of course, beyond their control. This is why it becomes a crisis. It could be the loss of others, such as seen in death, abortion, divorce, as we mentioned, employment, physical illness, or even suicide. A crisis can also be adventitious, which results from natural disasters. It's usually, again, not expected and not a part of everyday life, such as fires, earthquakes, riots, crimes of violence, rape, assault, murder, wars, airplane crashes. Those are all adventitious crises. So as the nurse, when you do your assessment, you want to look at the risk and protective factors of the individual. Protective factors are those factors that help patients to deal more effectively with stress. Like when I ask my patients about suicidal thoughts or any stressors in your life, I always ask, what are those things in your life that make you look forward to living, make you want to get up every day? So what are those things that you have to live for? What are those protective factors that helps you to work more effectively through your stressor? You look at their risk, their history of losses, their health, their age, their developmental stage, their support system. Do they have a husband to talk to when they go home having been fired? Are they single? Are they estranged from their family? Do they have a support system? Are they in therapy? Do they have a regular therapist they can call in when they need? So assessing one's risk factor as well as their supports is very, very important. You want to make sure this person has an outlet, has a support system, someone they can reach out to, talk to, someone to bounce ideas off. You're going to collect subjective data. Look at their perception of the event. One person may get fired and say, oh, I lost that job, I look for another one. While another person may be totally devastated having lost their job. So it is very, very important to get their perception of the event, because you might look at it and think, oh my goodness, they lost their job. And for them, they want to lose this job. They've been meaning to quit. They just didn't want to quit. And now they got fired. They got an employment. So there are lots of different reasons or thought processes that play into how one views a stressor. There could be cultural or religious factors attached. I had a new intake the other day, and it was very sad. It was a patient who was from an Indian country. I forgot. Well, it was from Pakistan. She was from Pakistan. Nope. She was from India, actual India. And she got married and moved here to Connecticut. And it was pretty recent. She got married like last October, moved here with her husband, and her husband became very physically abusive. So here she is in America with no supports, no social supports. Her protective factors are very, very minimal. She left everybody back in India, and she's going through a divorce. to make it even worse, she says, I struggle with it because I left because I was being abused, which is understandable. We'd be like, yeah, right on, you did the right thing. But in her culture, she has since been ostracized from her family she shares because she's going through a divorce. A divorce is something that doesn't happen in her culture, she shared with me. She's expected to work things out with her husband. So she's been living in a shelter for over a year. Her family, siblings in India do not talk to her. She doesn't have a relationship with her husband. So just put yourself in this patient's place and see how difficult it is for her to manage her anxious or depressive or crises that she's going through. And I asked, what are your support systems? She goes, well, I have a counselor. I've met a few friends since I've been in the shelter. And you want to hear those things. You want to hear that the person is connecting with others and building a circle around them. You want to counsel patients to seek information, to maintain control, to seek help. But sometimes you could be talking to a patient who does not have a previous mental health diagnosis, and you hear them talking about, oh, since I lost my job, I'm not eating, I'm not sleeping, I stay in my room all day. And while you're listening, you have some insight into mental health conditions and symptomology. So it is your role as the nurse to educate these parents, patients, I think it'll be best if you reach out to a therapist, just talk to someone, provide them with the resources also. Don't just make recommendations, provide them with them. How about I set up an appointment with you with this person? We have a therapist on board on the unit, something, but follow through with it. Encourage them to seek help. If it's something that happened on your unit, you probably want to complete a critical incident report, which will require you doing like a stress debriefing. It could be something you do like on the unit as nurses together. As usual, you always assess one's potential for suicide. So as you're asking about the stressor, precipitating factors, the support system, the protective factors, are you having thoughts of suicide? Hit the nail on the head. Are you thinking about killing yourself? You ask those questions directly. And if they say yes, remember some of the key things I said you should look for. You look for access, plan, intent, previous attempt, lethality of their methods, and you follow through likewise. You do your nursing care plan, which would require safety as being paramount. Identify the issues. Help your patient to set realistic goals and short-term goals so they can meet them and start feeling happy in their successes, not something that's going to require them to first get past this initial stressor or deal with the stressor before they can effectively manage it. You're going to work with the patient to decrease their anxiety. What are some things you can do to decrease your patient's anxiety level?
Stay calm.
Breathing exercises, yes. These are simple things, guys. These are things you know. These are everyday activities.
Therapeutic communication.
I'm sorry, I didn't hear that.
I said therapeutic communication.
Yes, it could be just in the way you approach them, the way you talk to them, you can get them sharing and talking. It could be guided imagery, it could be music, it could be, how about you take a warm bath, let's take a walk, let's engage you in some art therapy, let's go down the hall, they have a guest person telling the story. So just things to get them out of their head somewhat, things to relax them, increase their anxiety. You just mentioned therapeutic communication. That is very, very important. You want to be able to listen. You want to be able to listen and empathize with your patient. You want to make sure as you're listening, you are looking like you're interested and that you're validating their feelings. Clear communication skills. Use declarative statements. Avoid false reassurances. Oh, things will get better. Things will get better. I know you'll find a new job soon. You want to avoid doing that. You want to coordinate supports, like I mentioned. If it is that you have recommendations for them to follow through, make an appointment for them, give them the follow-up information so they can follow up as they discharge from your unit. You want to explore the possibility of medications. Maybe this patient has been in therapy for some time and they're telling you, I've been in therapy, it has not been helping, and this is where I am today. So maybe, how about you talk to our prescriber? We have doctor whatever who comes on at whatever time. Maybe you should sit with him and talk to him about how you're feeling. So explore different treatment options with your patients as well. And that is crisis management. I mean, at one point or another, we all face some amount of crises. And again, it's our ability to cope and work through them that makes the difference between us being inpatient, having a diagnosis, or being able to effectively work through our issues and moving forward. And we're going to look at anger management. This is an emotion of anger. It can be positive or it can be negative. Can anyone think how anger can be positive?
If someone did something bad to you, it can be a positive thing to be angry with that. If you're not angry, sometimes that signals something else might be wrong.
Yeah, and that anger, sometimes it motivates you to make positive changes, like promote change. So anger can be positive and it can be negative, whereas you can engage in not so safe behaviors, or it can be negative on you psychologically, where you're getting headaches, increased anxiety, increased depression, your blood pressure is up, almost getting a heart attack, or you had one. So anger can be both positive or negative. Suppressed anger can be expressed physically. So sometimes those somatic complaints plays into those anger symptoms. It can also develop into aggression towards others. Very often these patients have underlying feelings. So nobody's just angry for no reason. Usually there's an underlying feeling that plays into the anger. They feel fear, guilt, insecure, however they view it. It's often seen with depression, PTSD, patients who are psychotic, have Alzheimer's, or even personality disorders. So someone's angry, it's usually, as it says, it's comorbid. It usually goes hand in hand with somebody with some other disorder, and anger is an offset of this disorder. A lot of people think of mental health patients, like people ask me what I do for work, and I tell them, oh, aren't you worried they're going to hurt you? And sadly enough, that's usually the first thought that crosses someone's mind when they think of mental health. They think of like anger and rage. But research has shown that mental health patients are more of a danger to themselves and to others. So there can be different phases of anger. There can be a pre-assaultive, assaultive, and post-assaultive. Pre-assaultive is the beginning phase of anger, where there is anxiety, verbal abuse, hyperactivity, and just think of, if you can think of any interactions with probably like a patient who has been angry in your present, usually it starts with maybe them pacing, you can hear them hurling some expletives or saying some not so kind statements. Then they start acting out in violence, may need restraints, even medications. Then the post-assaultive, where the staff reviews the incident with the patient. So like you sit and process, this is what happened, how could we have avoided this, and how can we move forward? So pre-assaultive, assaultive, and post-assaultive, those phases. It is our key role, and as I mentioned, as we work with patients, it's always least restrictive first. So we should always try to eliminate the use of mechanical restraints. One, they're not very effective as learning tools or in changing behaviors. It probably just angers the patient. And make sure before you use restraints that you are actually following a doctor's order. There's like a whole protocol, and wherever you work will have a protocol regarding when you can put it on, how long you have to put it on, when you have to remove it, when do you need a new order to reinstate it. So make sure wherever you're working, you're following those protocols. And make sure wherever you're working, most of all, is that you're working to minimize the use of these restraints, because ever so often, especially in mental health field, patients will get threatened with putting on restraints because you do this and I'll have them strap you to the bed, or I'll have them put this restraint on you, because it makes for an easy shift. It makes so much easier for you to work through these issues when the patient is restrained, but it only harms the relationship, and it's not good, effective management of the behavior. Of course, if there's a safety risk and you need to then, that is totally, totally understandable. Some risk factors for anger. The patient has a past history of violence or impulse control issues. They have poor coping skills, limited support system. If they have a comorbid psychosis, delusions, hallucinations. What mental health disorder would you see like psychosis, delusions, and hallucinations with?
Schizophrenia.
Schizophrenic.
Yes. If they're living in a violent environment, or they run in the streets, or they're part of a gang, is this how they solve their issues? You want to make sure you're practicing consistent boundaries, that therapeutic communication, that therapeutic setting, consistent boundaries. So along with the patient expressing anger, there are some objective and subjective signs you can notice. You walk into the patient's room, the patient is pacing, they're restless, they have defensive response, they're easily offended. You want to make sure you're paying attention to like your eye contact. Eye contact is, in some cultures, it's necessary. In others, it can be viewed as offensive. If someone's saying, oh, F you and you this and you this and all of you nurses think you this, and is that the patient you're going to go in, walk into the room and maintain eye contact with as you talk to them? Absolutely not. It comes off as threatening or confrontational. You can look at their facial expressions. Are they frowning, grimacing? Look at those nonverbal behaviors, waving their arms, making a stance, making fists, increased breathing, increased speech. Are they under the influence of a substance? So these are all assessments you can make to determine the risks for violence, so you can take precautions. So, of course, safety is paramount. You want to make sure this patient is in a safe environment, as well as not just for themselves, but for others. So this is the patient who you, if you're going in to treat them, you make sure you bring a staff or two with you. Make sure you're following facilities' ethical and legal policies. And I guess this keeps popping up because when you get into the field of work, depending on where you're working, the lines get blurred very easily, because mental health patients can make for a difficult shift, because there's a lot of behaviors that present, and staff will devise their own ways of managing these behaviors. Just make sure whatever it is that you're using, incorporating, following is a part of the ethical and legal guidelines of your facility. You're going to assess for triggers. These are things that can precipitate or cause this person to fly into an angry rage. Sometimes it could be you yourself. Maybe something happened yesterday. Mr. Brown wasn't too happy with you. You walk on the unit today, and the second he sees you, he starts yelling and screaming. That's probably not the patient for you to go into the room several times. Oh, I need to do your vitals. You need to take this med. You probably want to talk to your supervisor. This is what I've noticed. This is what is going on. So you can probably get that patient off your caseload. You want to remain calm, speak softly and clearly. This is something that I have learned to hone and perfect as a psychiatric nurse practitioner, because I can tell you the things that I've heard in my ears. I can tell you the names have been called. I've had my office trashed more than once by patients, and I have mastered the art of remaining calm, speaking softly, and just maintaining my composure. And it is something that will come with practice. It probably not going to happen the first time it happens to you, maybe not even the second time. But as you hone in on those therapeutic communication skills, you will get better at it. You want to be honest, you want to be respectful. Again, therapeutic communication, we didn't just leave it in the first class, it follows us throughout our nursing career. You want to pay attention to personal space and touching. Some patients get very offended if you're just too close, or even if you touch them. Maybe this patient has a history of some kind of abuse. They don't like to be touched. Maybe touch is a trigger. As I mentioned before, you want to avoid threatening statements or actions like, oh, you keep it up and see what happens. Oh, when your phone call comes, I might not send it to your room if you keep talking to me like that. So you want to avoid those kind of statements. You want to describe the patient's options appropriately and clearly. Mr. Brown, you can either take the meds now or I can come back after you have showered. Not, oh, you better take these now because I don't think I want to come back in here. So therapeutic communication, therapeutic communication, therapeutic communication. That is going to be key in de-escalating your patients and working through any issues that present. You want to be reasonable, of course, set limits and boundaries that they can adhere to. Your care plan, you want to use physical activity, such as walking to decrease their anger. Sometimes they'll have medications on that's ordered like PRN for agitation or irritability. You want to make sure you have supports inside, other staff members that can help you. You want to talk about the incident with the patient. So don't pretend like it didn't happen when Mr. Jones mouthed it off to you earlier in the shift. You wait until it's an appropriate time. You go in there, you process with them. I noticed you were a little irritable earlier. Can we talk about what happened? Why were you feeling this way? You want to make sure you process with them. And if there are any incidents or anything that happens on the unit, you want to make sure that you document. A lot of times patients get hurt in restraints or patients hurt themselves. If you didn't document it, it didn't happen. It doesn't matter how much you can explain it away. You want to make sure that you have it in writing. There can also be family and community violence. This is violence towards another in a social act of serious abuse of power. It's often between spouses or parent-child, child towards parent, groups or strangers. So usually it's between two parties and it's an interpersonal issue. Sometimes there's violence against the mentally ill. It's often due to ignorance because everybody think they know what mental illness is. Everybody think mentally ill patients should be feared. And because they fear them, they approach them with anger. It could be against poverty or from substance abuse. If a patient has a history of violence, it kind of speaks to their potential to engage in future violent behaviors as well. So that's why when you do your intake, you ask about risk, engaging in risky or harmful behaviors, because you want to make sure you tease those little things out early. If this is Mr. Jones in his room pacing, calling you names, and he told you that he had stabbed someone before, then you know he has the potential to engage in these violent behaviors. As you do your assessments, it is key to note that female partners are usually most at risk, but also key to note that women can also be the abusers. So the abuse doesn't necessarily have to be a woman, it can be a man as well. The greatest risk of violence is when one partner tries to leave. You have protected classes like children and pregnant women, the elderly. They're usually at a higher risk for violence. And violence seems to beget violence. So if you have a child who was raised in a house where he was treated violently, and as he shares his social history with you and tells you how he was beat upon by his parents or his siblings whenever they had a disagreement or something, then it kind of gives you some insight as to how this person will handle situations should they come up in their lives. Sometimes there are cultural factors that play an issue into how one addresses or speaks to or even acknowledges violent behavior. This cycle of violence, especially in domestic situations, is very difficult to break. Very often there's tension, an acute battering phase, a honeymoon phase, escalation, de-escalation. So very often it's almost as if like it's a whirlwind up and down cycle. So when you're assessing, make sure you're asking about all these different avenues. So there could be physical violence as well as sexual violence. It could be psychological or emotional. It could be neglect. It could be economical. or it could be those specific to the victim's characteristics, such as they're vulnerable, they have a low self-esteem, they have a sense of hopelessness, guilt. Like they'll say, I deserve it. Even very often, especially as it relates to like domestic violence, they will try to protect their abuser, sometimes out of fear. The abuser characteristics, they often use threats. Like for the parent who abuses their child, they'll say, you know what, I have to discipline him. He needs some discipline. So they will um, hide behind that so-called discipline as in to say that's what they're doing. They believe in this punishment. They have difficulties with their role. Maybe it's a parent who is struggling to make ends meet, and little Johnny's just not doing what he's supposed to do. He's skipping school, stealing money, and this is how they choose to deal with the stressor or the issue that they're having. They too may have likely to been abused themselves as children. And it's very important that we look at the cultural aspect of this too, as I am from a culture where disciplining one child is totally different from how it's viewed in America. Like growing up, I got thrashings, spankings, and we call them beatings in Jamaica from my teachers at school, from my parent at home, and it was a normal part of society. Of course, that would not fly, not for a second here in America, because it would be deemed physical violence. And I'm sure as I listen to my patients talk and they talk about their history and their youth, I will hear them say, oh, I was physically abused as a child. And you delve more into it and you're like, oh, I was physically abused. Is that what was happening to me the whole time? But because our cultures are different, I didn't view it as such. I viewed it as what it was deemed to be a form of discipline. So a cultural aspect also plays a part in how the patient views their violence as well. So there are also age-specific signs of abuse, and I'm sure you guys have covered this before because I remember when I was in nursing school, it wasn't just specific to psych. We spoke about these, like infants. There's the shaken baby syndrome. You could have respiratory distress. You're working on the infant floor or the children's hospital. They have bulging fontanelles, retinal hemorrhage, increased head circumference, bruising. Before age 6 months, a baby with 6 months is probably just laying there. Why is this baby bruised? Those are questions you should ask. You have the preschooler and the adolescent. Unusual bruising on the abdomen, back, buttocks, genitalia. They have numerous bruising, maybe shaped like a belt buckle, baseball bat. You're assessing for burns, round gloves. The fractures are not agreeing with the history. They're telling you they walked into a door but their arm is broken. It could be human bite marks. It could be head injuries. Make sure you're checking their pupils. And I think I mentioned to you that I worked as a school nurse for 10 years. I worked as a school nurse. So specific signs of abuse was a big part of my job, as very often teachers would send children down to the nurse's office. Take a look at little Johnny's arm. Take a look at little Johnny's face. And it was never my job as the nurse to determine, to ask the child in depth, like to do an investigation as to what happened. It was my job as a mandated reporter, and as nurses, you all will be mandated reporters, to call the authorities and report what I've seen and hand it over to them to do an investigation. But you will almost always come across some case like that, where something presents and you have to follow through. Just remember, if you don't report it and you knew about it, you can also get into trouble for not making that report, okay? Because sometimes I can tell you little Johnny came down and little Johnny told me, oh, I told my mother to, what did you tell your mother? And that's what she did? But I still have to follow through and make that report because you have to work to address the child's best interests or the adult best interest. Sometimes it could be an older adult who has bruises, lacerations, fractures that are not matching their history or mechanisms of injury. Sometimes they have grab marks, bruising all over their arms. I remember I had one patient, was an elderly patient, who always came to the visits with her caregiver. And the caregiver would the patients, okay, would join in the visits. But I noticed whenever the patient choose to speak, she would first look at her caregiver as if looking for approval or as if fearful. I wasn't quite sure. So after a couple visits, I informed the caregiver that she would have to wait outside the office and we would do the visits without her. And after that started happening, I got a whole lot of reports, a lot of concerns, a lot of issues that were presenting between the relationship that would not have been divulged in her presence. So as you ask your questions, you want to make sure you're in the right setting and the patient has freedom to speak. If it's a wife you're asking about an abusive husband, she's not going to tell you in front of him he's abusing me. Maybe you could say, hey, sister, whatever your name is, you can wait here while I take Mrs. over here to get some blood drawn or to do her vitals, and you use that opportunity to do your assessment. Your nursing care plan. Remember, as I mentioned, you are a state mandated reporter. There's a time frame as to when you learn of the incident as into when you need to report it. I'm sure when you're in the world of work, you're educated more about this, but just know that it is your job to report these incidences. There's a Tarasoff doctrine. This is where providers, like psychiatrists, has a duty to protect or warn a third party if they believe a patient poses as a risk of inflicting bodily injury onto another. Like I had one patient who told me she was, I think I mentioned it to you guys, who was going to go home and stab her boyfriend. I'm like, what do you mean stab your boyfriend? She goes, yes, I'm going home to stab him. And I'm like, why? She goes, well, he works in landscape and every year during the winter months, he just sits at home and drinks, and I'm buying his alcohol, I'm buying his cigarettes, and then he just talks down to me, and I've had it. That's where all my extra money is. I've just had it. So I'm like, how are you going to do it? She goes, I'm going to stab him. With what? With the kitchen knife? And she was very matter of fact, whether she was joking around or not. I didn't know that. So here she was expressing homicidal thoughts. So she was sent off to an acute care setting, and we had to get in touch with the company lawyers to see what Connecticut's rules were as it relates to informing her partner that she had made these threats. So make sure you're not flying solo or going gung-ho when you address these issues. Make sure you're seeking the assistance and guidance of departmental heads, supervisors, so you can work best in the patient's best interest, as well as stay within the confines or the limits of what's legal. It could require a critical incident stress debriefing. As I mentioned, this is just talking through the issue, what happened, how it happened, what could have been avoided. You may need trauma-specific interventions, therapy, skills teaching. Maybe it was something that was even traumatic to you, something traumatic for the patient that needs to be addressed further. As you look at discharge planning, you want to help the patients to identify their triggers, see what's happening, why it's happening, how they can avoid being around these triggers. You want to help them to develop a safety plan, to coordinate with community supports, their doctors, social services, whoever is in their circle to help them to carry out these plans. Help the patient to identify their own stress, increase their coping skills, self-care. And we have sexual assault. And I was not aware that sexual assault was this common until I got into this line of work, and you ask people about past traumas, or usually past traumas, and they divulge to you that I was sexually assaulted, I was raped, it was a family member. Like, it is so common that it was very appalling to me. So sexual assault is a forced or pressured sexual contact, including it could be sex talk, inappropriate touching, intercourse, incest, even rape. Right? Rape is a crime of violence, control, and power. Usually it's by someone the victim knows. Very often there's drugs or alcohol or some sedative component. So the patient would have induced, be it Ruth's or ecstasy, and a list of names are listed here: Kit Kat, Black Hole. It's out there, and the perpetrators do know how to use them. So when this incident happens, some victims suffer very long-term effects from the trauma. They may develop rape victim syndrome, which is similar to PTSD. This is where they have like a disruption in their normal physical, emotional, cognitive, and interpersonal behaviors. So it affects very, very large component of their functioning. What are risk factors for rape? I mean, there's no typical victim. Nobody walks around with a t-shirt that say, I'm a typical victim. I mean, it could be anyone. It depends on the perpetrator. It can be both male or female. It could be as simple as taking a jog, or going to a party and having what you think is a good time. You want to make sure you're educating your patients about drinking from open containers or open drinks offered from others. Listen for subjective and objective data. Listen to how the patient described what happens. Oh, it was my fault. I asked for it. I shouldn't have been there. I did tell him yes, so maybe I let him on. So you want to make sure you listen to your patients and helping them working through this issue. Not that you're going to engage in like a full-blown therapy session with them, but you're going to practice therapeutic communication styles and connect them to the appropriate person to work through these issues, which by all accounts would be a therapist. Then you're going to look at your assessments. There is like a reorganization phase where the patients could have flashback, nightmares, increased anxiety. There's a change, there could be a change in sexual activity, which will affect their future relationships. It could be having mood swings, somatic complaints, depression, even start using substances. So there is a lot of importance to this patient getting the help they need at the appropriate time so they can effectively work through the issue and hopefully return to an acceptable level of function post-incident. If possible, you're going to get them in touch with a rape trauma counselor. As a nurse, you want to look at your own self-assessment. You want to look at yourself. Were you yourself a victim of rape? Was your parent or a close family member a victim of rape? How do you feel about, was your brother accused of rape? So how do you feel about rape victims when your brother wasn't guilty? So you want to make sure you're doing a self-assessment because it'll definitely play into how you address this patient, how you work through this patient effectively to see if it is that you need supervision, you need to talk to someone about how this works. Assess the victim's level of anxiety, their coping skills, their support system. Is this a patient who lives alone and she was treated in the hospital and you're like, okay, you can go home now? No, you want to make sure this patient has supports in place. Maybe they can go stay with someone for the night, the weekend, have someone come stay with them. Encourage the victim to verbalize their thoughts and feelings, be empathetic, be an active listener. Assess their physical needs and their injuries as well as their emotional needs. You want to be supported during their exams and assessment. They will most likely require prophylactic treatment for STDs, evaluate for pregnancy, provide protection against. Discharge planning. Here's who you should call. Here's the number. Review the plan of care with the patient. Remember, we set up an appointment for you to meet with X, Y, and Z on this date. They're very anxious. They're in the midst of their trauma. They're probably not listening very well. Make sure you're reviewing the stuff that you're saying to them. Make sure you're giving it to them in writing. Emphasize the need to reach out to others. Emphasize the need to use their support systems when they're no longer in your care. Encourage psychotherapy. be it individual or group. And as I mentioned, arrange for follow-ups as appropriate. And that is crisis management, anger management, family and community violence. Any questions? Are you guys there? So we are going to take a break
Yes.
for, we're going to take a 10-minute break only because I need to rest my voice. I need to drink of water. Okay? So I'll see you guys in 10 minutes. didn't even watch the video yet. Cold. I know. I bought it and then I changed my mind. Well, I bought it and didn't come and I got this one in my shorts. I just haven't popped off or anything, so. Hello guys, welcome back. Anxiety disorders, trauma and stress related disorders. So this is where I live. Everyone back? Okay.
Yep.
Yep.
It is kind of difficult talking to nobody. Glad to know you guys are out there. So anxiety disorders, as I was saying, this is where I live. Anxiety is a very, very common disorder. There is, without a doubt, I have no doubts rather that you will encounter patients with anxiety disorders. Now, the next slide offers a long list of different anxiety disorders: panic, agoraphobia, social OCD, PTSD, acute stress, GAD, hoarding, hair pulling, excoriation, impulse control. So there are lots and lots of different disorders that still fall under the huge umbrella of anxiety disorders. So in anxiety, I experience it, and I'm sure in nursing school you experience it. We all experience anxiety. It is an awareness of an impending danger. It could be insidious, diffuse, vague, or an apprehension to the unknown threat. You could just be anxious because of what's unknown. You don't know if you pass that test. You don't know how you will do. You don't know what the future holds. Like, there's lots of reasons what patients worry about. It brings an unpleasant feelings of uneasiness or sometimes even helplessness. You don't know and you don't know how to fix and you have no way of solving this issue. So it can also bring about some helplessness. This internal perception of threat or dread can be imminent or in the future. So it doesn't necessarily have to be something that is happening now or something concrete. It could be something that they perceive will happen in the future. As I mentioned, it's one of the most common disorders. For some reason, women are more anxious than men. Research says maybe women come forward more than men. Who knows? But it is said that women have more anxiety than men. There's an increased prevalence in lower socioeconomic demographics. And what do you think could play into that factor?
Just more uncertainty.
As well as more stressors, more lack of coping skills, less therapy, less. So lots of factors play into the lower socioeconomic lifestyle that could account for increased anxiety. What causes anxiety? So there is one theory that it could be biologic. It could be genetic. Your mother, very often I had one intake last week. It was a teenage girl. And as I'm doing her intake and mom's sitting next to her, I could tell you mom had anxiety just from the interaction. So the daughter had anxiety until mom came out and said, hey, and I have anxiety. And my mother has anxiety. So it could be heritable or genetic. It could be how one's psychodynamic function, how they work through their internal struggles with their impulse and drives, so that's how they work through things. It could be interpersonal. It could be through their experience. Maybe you lived with an anxious person and by default you have become anxious, or you've learned these coping ways of dealing with stressors and you develop these anxious symptoms. It could be, as I mentioned, learned behaviors like you're conditioned to act in this way. There are some medications that can cause anxiety. And on this list of medications, we have like corticosteroids, some thyroid hormones, we have SSRIs, psychotropic meds, those are the antipsychotics, or even chemotherapy meds. And in the midst of those meds, I mentioned the SSRIs. What do we know about SSRI medications as it relates to anxiety?
The first line treatment for anxiety.
Yes, they're used to treat anxiety, and you're like, wait, they treat anxiety, they can cause anxiety? Yes. One of the side effects is they can cause increased anxious symptoms. How often does it happen? I can tell from my experience, not very often. So some of the hallmark symptoms, these are the definite, this is anxiety, this is what's going on. This patient will have physical symptoms. And has anyone ever encountered anyone or been around anyone who has anxiety? What are some of the physical manifestations you have noted or present with anxiety?
Tightness of the chest, heart racing.
Yes. Hyperventilating, I see Samantha put there.
I have anxiety, so.
Okay. The sweating, the shaking. So lots of different physical manifestations. It could be affective. They just have this wide eye look on their face. They look anxious. It could be behavioral, the pacing, or cognitive, they, how they reason through it is through anxiety. It could transform into behavioral manifestations. Patients tell me when I get anxious, I eat. Or when I get anxious, I drink because that is what helps me to quell my symptoms. They could have difficulty sleeping. Or I could say I exercise when I'm anxious. Or I smoke. Some people will even have somatic complaints, especially like in children. They'll have those headaches, those dizziness, those little somatic complaints they complain about, and it's because of their anxiety. So the pain, the GI symptoms, and for them, this is real, but this is how their anxiety manifests. It could be respiratory issues, urinary issues, lots of different factors play into how one presents as anxious. There are different levels of anxiety. It could be mild, as in related to the tensions of day-to-day life. It's not a problem. When your senses are sharpened, you get more motivated, you're alert, your learning increases. Like I'm sure as you guys prepare for this final exam, you will have some amount of mild anxiety, which would prove to do well because then look at all those positive things that happen when you have a little bit of anxiety there. Your sharpened senses, you're motivated, you're alert, your learning increases because you're like you're probably listening because you have to listen because I need to know this stuff for my exam. So a little anxiety is not always a negative thing. So that's mild anxiety. Then we can move on to moderate anxiety, where this is more of a confessional state with the patient or the person will have more selective attention because they have this inability to concentrate. So this is why a little anxiety is good, but when it becomes a little more than a little, it becomes problematic. Because now you're so preoccupied with being anxious that you can't, you're probably not hearing nothing I'm saying. Because you think, oh, this is so much information, I can grasp this all. And I don't know why I have to sit and listen to Zoe talk at home in the evening. Why aren't you in the classroom? So you're so anxious about this entire thing that you can't relax enough to learn. You're able to concentrate, you have muscle tension, you're restless, and you start using defense mechanisms. Oh, I failed a test because, and you find another direction to point this in. Did you guys, I'm speaking of defense mechanisms, did you guys take a look at the different support materials that Pam had put up, the videos and the defense mechanism handouts and stuff? Crickets?
Not yet.
Okay, well, just so you know, it's there. I was a student, I understand. Then we can have severe anxiety. This is when it becomes pathological. There is total decreased or diminished concentration. Attention, very limited. Learning, not effective. Increase in somatic symptoms. Responses are not appropriate to the danger or the threat. So very often how their anxious response is not in proportion to the danger or the perceived threat. And these responses will continue long beyond the perceived or potential danger. So say they were anxious regarding one specific thing, long after we have worked through and passed that issue, they remain anxious as they work through those feelings. They'll have intellectual, cognitive, social, or impairment in their occupational function. So this is the patient who's telling you, I'm getting in trouble at work because I'm missing things, I'm not counting the money right. Um, I stop hanging out with friends because when I'm out, they don't like hanging out with me anymore because they say I'm too hyper for them. So it affects their not just their everyday life, but every aspects of their life. And it can also progress from severe anxiety into a state of panic. I have patients that tell me I had a panic attack. And a panic attack is a severe level of anxiety where the patient has an inability to understand simple directions. There's a risk for a heart attack. There's suicidal ideations. They have difficulties differentiating between what is real and what isn't. They have delusions, can even start having hallucinations at that time. There's impairment in their interpersonal functioning. They there is no concentration there. Has anyone ever seen anyone in the midst of a panic attack? Yes, yes, it is. And how did you perceive it to be or view it to be? Was it just a run of the mill, oh, she's anxious, or was it frightening?
It feels like the end of the world.
Yes, there's a feeling of impending doom. They feel like they're dying. And you're like, anxiety? Yes, anxiety. Panic attacks. So very often if patients have like a panic attack or recurrent panic attacks, they're usually followed by persistent concern about having another panic attack. And this is how they work themselves up into a tizzy. They had one panic attack, then they're worrying about, oh, I don't know when my next one's going to happen. I'm afraid I'm going to have another one. So worrying about the possible implications of their attack and start changing their behaviors and stuff related to their attacks. Oh, I don't want to go back to school because I had a panic attack at school last time and everyone's going to judge me and this is how everyone's feeling about me. So they spend a significant amount of time after the incident worrying about it. Of course, there's a disclaimer statement there, not due to any direct or psychological effects, substances, or medical condition. So we're going to look at one specific type of anxiety, agoraphobia. This is a fear of places and situations that may cause panic, helplessness, or embarrassment. Often develops after one or more panic attacks. So the patient will overestimate the risk and their anxiety is usually out of proportion. Situations are often avoided or endured with marked distress. So it could be standing in line, riding a bus, being out in public, being in a crowd, like lots of different reasons. And you're probably like, oh, okay. But these are things that are real. These are things you hear patients say all the time. I can't take the bus because once upon a time I was on the bus and I had a panic attack. And since then they've had a fear of riding the bus. So different reasons will play into why they start having these phobias. There could be also specific phobias, which are intense, irrational, persistent fear or response to the specific object or situation. Any exposure to the stimulus provokes immediate anxiety. For me, it's any kind of reptiles. I don't like reptiles. I was raised in Jamaica where we had a lot of lizards. I just couldn't, and I still can't. In children, they will respond by crying. They'll have tantrums. They're freezing, clingy behaviors. And I must say, in adults too, you'll see these behaviors or this response from adults. Patients often recognize that their fear is unreasonable. It interferes significantly with daily routines or social life, often leads to avoidance behaviors. Like they won't I'm definitely taking trips home, but some people would say I will never go back to that place because I'm afraid of those lizards. So that would be heightened and irrational. They will avoid these places or avoid having that behavior repeat itself. Again, to be diagnosed with a specific phobia, at least 6 months under age 18. Some behavioral treatments that can be very effective. It can have systematic desensitization. This is where the patient is exposed progressively to the anxiety-provoking stimuli and they're taught relaxation techniques. Or it could be an exposure and response prevention where the patient faces the fear and let their obsessive thoughts occur with some neutralizing compulsions. Or flooding, where the patient learns to associate the feelings of relaxation with fear, with the fear-inducing stimulus. So there are lots and lots of different approaches to how a patient with a specific phobia is treated. Does anyone in this class have any kind of phobias? Yes. Also very few.
Snakes.
Okay. Snakes. Yes. Any kind of, I don't like any of those things myself. And I will avoid places and situations that put me in contact with those things. So it could be of the animal type. It could be the situation type. Anything health. You have a fear of anything health related, Amanda? Is that what you're saying? Oh, hypochondriac.
I do not like clowns.
Ah, and that has become very popular lately with the movie It. It could be the blood injection type injury. Trypophobia. What's that, Amy? Yes, I do know about that fear. I have one patient who does have that fear. Clusters of holes, and she says she'd be driving on the highway and then she's behind trucks and all those little holes that come in the back, and it kind of like she goes on and on about the patterns and the lines. So these fears are real in patients. They do have them, and as nurses are about to be nurses, you're saying you do have these fears yourself, which can work to help you to empathize with your patients as they work through their struggles. Hopefully you have learned to work through yours effectively. It could be the blood injection type, where some patients will have the vasovagal response. When I was in the Air Force and I would spend long days doing injections on these muscular looking men as they walk in, I'd be like, oh, I just can't. Or they'll have to have a seat for their injection. It was somewhat amusing, but it was in fact a phobia for them, and it was real. It could be to a specific stimuli. So here are some medical terms which you should familiarize yourself with. There's acrophobia, and makes it very easy. Acrobat, heights. There is algophobia, pain, alorophobia, cats, erythrophobia, blushing, panphobia, fear of everything, claustrophobia. That's very common, used very commonly. I'm sure a lot of people know what that means. There's xenophobia, fear of people from other countries, and zoophobia, a fear of animals in everyday life. So that's like cats, dogs, just the regular run-of-the-mill animals you'll see running around. So that's different types of phobias. Then you have a patient who has a social anxiety disorder. This patient has a marked or persistent fear of social or performance situations, usually under scrutiny of others, like we are right now. I'm looking at a screen. I don't know who's there. I don't know what you guys look like. And I know you're looking at me. I know you're judging me. I could have a fear of this thing, guys. It could be called a social anxiety disorder, but I'm coping effectively. I'm moving through. So this is a fear of being embarrassed, rejection, or a negative evaluation, because I don't know what you guys are thinking. So that in itself could cause a fear. It may also include eating in public, speaking in public, exposure to situations almost exposure to situations almost always provokes anxiety in the patient and may even lead to panic attacks. So if this was a true fear of mine, and here I am talking to you guys, and even though I'm talking to you guys, I'm in my head, I'm reasoning, I wonder what they're thinking, I wonder how they're looking at me, do I look okay? And I'm asking all these questions, then it could even lead to me having a panic attack. Next thing you know, my video dies, you're wondering what happened. I could be working through some serious issues on my end. So it can develop into a panic attack. The patient will recognize that this fear is excessive or unreasonable, and they will try to avoid these situations. In children, like I mentioned, it'll be more than like an atypical presentation where they will throw tantrums, they will come off as anxious, they will have those somatic complaints. Then we have OCD, where everybody wants to say, oh, I'm so OCD. It's like the most common diagnosis for everyone to claim. But after we discuss OCD tonight, hopefully you can tell the next person who shouts to you, I'm so OCD, that you can correct their misunderstanding of the terms OCD. So OCD is intrusive, recurrent, persistent thoughts. So this is a patient who has intrusive, recurrent, and persistent thoughts. Those are the obsessions. And in order to relieve these thoughts, they're compelled to act. So they have uncontrolled repetitive behaviors. And these behaviors, it causes the patient's distress. So obsessions and compulsions, obsessed with the thoughts and compelled to act to relieve the thoughts. It is developed as a way or means to control the anxiety from those persistent thoughts. So they're having these thoughts, recurrent, intrusive, persistent, so they act in a certain way as a way to control the anxiety. The obsessions are recurrent and persistent. They could be urges or images that are intrusive and unwanted. The individual will attempt to ignore or suppress or neutralize these thoughts or urges or images by performing the compulsions. These compulsions are repetitive behaviors or mental acts that the individual feels driven to perform. Behaviors or mental acts are aimed at preventing or reducing anxiety, but not connected in a realistic way to what they're designed to neutralize or prevent. So if they're having some intrusive thought and they choose to hand wash, it doesn't mean that they're having thoughts about hand washing. Is that kind of clear? So you can have patients who are choosing to check things over and over, checking windows, checking doors, counting things repetitively, counting everything they see, ordering objects. Hand washing is a very, very common one. Has anyone interacted with or know anyone who has an obsessive compulsive disorder?
Yes, I have.
You're asking what's the difference between OCD, obsessive compulsive disorder, and obsessive compulsive. Is that a personality disorder? What's the PD? What's the P?
I believe it stands for personality disorder. My best friend actually is diagnosed with it. And I was wondering like what the big difference was between it.
I mean, OCD is OCD, and we have a lot of different personality disorders that fall into different clusters. Probably it would fall under those that are like more anxious. So it'll be the same thing, pretty much.
Yeah, because she does have the OCD tendencies.
Yes. And what's her compulsion?
She has many different ones, but the ones that I have seen fairly recently, compulsive cleaning and hand washing, and then compulsive locking of the doors and making sure that everything is locked. She also has a habit with numbers.
Okay, so she has quite a few of those compulsions.
Yes.
And it often causes these patients a lot of distress. Is she distressed at all by these actions?
Yeah, especially with numbers. If she doesn't do something a certain amount of times, it causes her a lot of anxiety. Like she checks the doorknob 4 times, she kisses her husband 4 times, she has to lock her car 4 times. Has an obsession with even numbers, so if like the volume on the radio is an odd number, it causes her a lot of stress.
Yes. And just imagine having to deal with these obsessive thoughts and compulsive behaviors. It consumes you. It can interfere with your work, your social life, your interpersonal functions. It can interfere with your life across the board. And this is why it's important to help the patients to work through these feelings, to work through these thoughts, so we can help them to function as best as they could. Remember, the patient recognizes that these thoughts and behaviors are excessive or unreasonable. They often feel a need to control the bad thoughts, and this is why they engage in these compulsive behaviors. It is said that 30% may have a tic disorder, and we spoke about that last time, and they are usually treated with anxiolytics. So because anxiety is propelled, because OCD is propelled by anxiety, we choose to treat the anxiety, and very often it also addresses the OCD symptoms. The number one drug you'll often see prescribed for OCD is nafranil, which is clomipramine. Usually that's what patients take for an OCD disorder. Then we have post-traumatic stress disorder. This is symptoms that develop after someone experiences or is involved in an actual or threatened death or serious injury to self or others. So it doesn't have to be something that happens to them directly. It could be something that happened to their child, their loved one, but they are so affected by it that it causes them stress. It could also be yourselves as nurses. or first responders who have a repeated exposure to traumatic events. What if you work in the ER or you join the military and you go off to combat? It could also be healthcare workers or first responders. Usually PTSD issues that causes intense fear, helplessness, or horror. This patient will have persistent flashbacks, intrusive dreams. They'll have a persistent avoidance of stimuli associated with the event. So if it is, they can pinpoint their traumatic event to something happening, they usually choose to avoid that stimuli. They could have hypervigilance or an increased startle reflex. So maybe they were assaulted in public or something, and who was that? So an increased startle reflex because they are just always on edge about this incident reoccurring or reliving the feelings that they experienced when they had that incident. They'll have difficulties enjoying life. Very often, important to note, these patients can present as angry and irritable. So not just anxious, but angry and irritable. Symptoms will present for more than a month, cause significant distress, as well as familial marital distress as well. Then we have an acute stress disorder. As acute means exposure to traumatic event or serious injury or threat. The patient's response will be intense fear, helplessness, or horror. Trauma is re-experienced in images, thoughts, dreams, or flashbacks. There's marked avoidance of the stimuli. This patient will also have an acute arousal, difficulty sleeping, poor concentration, irritability, hypervigilance. They could have some dissociative symptoms such as the detachment, having like out-of-body experiences, depersonalization. These symptoms would last at least 2 days, maximum 4 weeks. So I went right into acute stress disorder to point out the difference. Say something traumatic happened to the patient and they're experiencing these symptoms. They sound a lot like PTSD, yes? But it would be difficult to say someone has PTSD in the early onset of the symptoms. So it would probably start out with a diagnosis of an acute stress disorder before it being diagnosed or developing into PTSD. Is that clear? Then we have generalized anxiety disorder. So this is just free-floating anxiety. There is usually no precipitant, nothing causing it specifically. This is the patient who is just baseline anxious. This is the patient that has excessive, that's me. This is the patient, and I'm sure as we go through these different disorders, you guys be like, that sounds a lot like, or that's me. So very often as you listen, don't start diagnosing yourselves. This is excessive anxiety and worry lasting at least 6 months. It is recognized by the patient as excessive, and they have at least 3 of the following: restlessness, they're on edge, fatigue, poor concentration, irritability, muscle tension, they have problems sleeping. This anxiety will cause significant distress or impairment in function. And I can share with you that this is also a very common disorder. So you will definitely encounter patients that have GAD. GAD, generalized anxiety disorder. Some of the assessment tests we can do for GAD is like the GAD-7, where you give them this questionnaire, they answer, you can see how they rate. What is GAD treated with? What class of drugs?
SSRIs.
SSRIs, yes. Also in the anxiety disorders, we have a hoarding disorder. And this is the patient who has persistent difficulties discarding or parting with possessions, regardless of their actual value. I have one patient who has a hoarding disorder, and she is very distressed by it. And it's important to know that these patients, they're not choosing to hoard. It is a disorder. This is something they struggle with. This is something they have a hard time dealing with. They have difficulties due to the perceived need to save the items and avoid distress, and in order to avoid the distress they have with discarding the item. Hence, it results in accumulation of possessions that clutter their living spaces and compromises the use of their living spaces. The hoarding, it causes significant distress or impairment in social, occupational, and other functions of life. It is not attributable to any other medical conditions. And we have trichotillomania. And I have a few patients with trichotillomania. This is the patient who pulls their hair. Recurrent pulling of one's hair with noticeable hair loss. I have one patient that has pulled out all of the back of his hair. I have one girl that pulls out both sides of her hair. I have a very young girl that pulls out all of one side of her hair. She just constantly just pulls, pulls, pulls. And it's important to note that it's not necessarily just hair on one's head. It could be eyelashes, it could be body hair, it could be pubic hair, hair anywhere on their body, but it's a hair pulling disorder. The patient will have a sense of tension immediately before pulling out their hair, and they will pull the hair to relieve this tension. It brings pleasure and it's gratifying. At the same time, it does cause significant distress and impairment. Anyone ever encounter anyone with a hair pulling disorder?
My brother did that when he was in elementary school. He would twirl his hair on the school bus and pull it out until he had a bald patch.
Yep, it does lead to a bald patch. If they pull it out often enough, sometimes it stays that way. Someone saying their neighbor, someone saying my daughter, a 5-year-old, your daughter's school has this since she was 2. Yes, they pull all their hair out. Some people are without eyelashes because they sit and they pull them out. That's trichotillomania. And there is excoriation disorder. I have one patient with an excoriation disorder. This is repeated skin picking resulting in skin lesions. Most use their fingernails, but it could be tweezers, pins, or other objects. My patient that I mentioned, she uses her fingernails. And though she tries repeated efforts to stop, it is most difficult. Every time she comes to me, she has bright red patches on her face, and those are the skin areas that she's picked off. And because of that, she doesn't want to come to the appointments because she doesn't like the way she looks. So it impairs her social, occupational, and other functionings. She doesn't want to get a job because, oh, I don't like everyone's going to look at my face. They're going to talk about my face. And this is where it leads to other issues. They often feel shame and disgust. That is an excoriation disorder. And I have a funny story. Well, I think it's funny. I remember I was doing an intake on a new patient one day, and as I sat across from her, so as I am assessing my patients verbally, I'm also looking for my own objective data. I noticed that she had several excoriated areas on her legs, and I'm like, excoriation disorder. So I already knew that's what was presenting. As I get around to my questions and we're wrapping things up, I'm saying, oh, and I also noticed that you have some areas on your legs that are rubbed off or look like you've picked the skin off. And she goes, oh, that's from my crack pipe. And I was like left baffled. It was like early spring, right after winter. And that's when the patient educated me that during the winter months when she used her crack pipe and she wore boots, she would stick the crack pipe into her boots and it would burn her skin. So it wasn't her picking at her skin. There was all those many excoriated areas that I noticed were from her crack pipe burning her legs. So I say this to say, don't assume. Ask your patients what caused this area, or I notice you have this here. Can you tell me how you got that? Okay? Yes, I was left baffled. And educated. I didn't know crack pipes got hot, but I learned that day. Then we have impulse control disorders. This is a patient who has trouble controlling their emotions, their behaviors. They often violate the rights of others or have conflict with societal norms. This could be a patient who engages in gambling, pyromania, which is the starting of fires, kleptomania, stealing, or they have an intermittent explosive disorder, IED. Remember we discussed this in children? This is a sudden explosive anger or they act have other acts of violence. This is an different impulse control disorders. So they have this impulse and they have a difficult controlling it, and so they act on it, and it can lead to those behaviors. So how do we treat these disorders? As we mentioned, we use anxiolytics or SSRIs. SSRIs, even though they are mostly marketed for depressive disorders, very often they treat concurrent depression and anxiety. Cognitive behavioral therapy, we spoke about that type of therapy. We said it seeks to look at the patient's thoughts, their feelings, examines them, and seeks to help them to work through those behaviors. Relaxation techniques. If you're anxious, the key is to learn how to relax. And this is why, even as nurses or student nurses, you have to find time for you. Like I have a pretty busy schedule, but Fridays are mine. That's a day I get out of work like at 12 noon every Friday. When I go out to dinner, I watch a movie, or I lay in bed for the rest of the day, do nothing. You have to practice some amount of de-stressing and self-care. And it's very important that you, no matter how busy your lives get, that you find time to do that. For the specific phobias, we looked at some of these techniques before, where it could be exposure, flooding, or different types to expose the patient to the different treatments. Some anxiolytics that are used are benzodiazepines, and this is like the bane of my existence. This is the #1 drug that every anxious patient wants because they work. That's the Valium, the Klonopin, the Ativan, the Xanax. They absolutely work. But what else do we know about this class of drugs? Does anybody have any information about these drugs or any insight into this class of drugs? They're addictive. What do we know about addictive drugging on the streets?
They're worth a lot of money.
Yes, they have a high street value. So pretty much every patient wants it. I can't tell you how many times I've prescribed a 30-day supply and I get a call 2 days later, oh, I dropped them down the sink or I lost them. And I'm not saying every patient who takes these drugs is abusing them. I'm just letting you know that these are drugs of abuse, but they do work. These are not drugs that you'll see prescribed often long-term for patients. However, there are some patients who do take them long-term. These are drugs that are for more PRN, take as needed use, usually for short-term. Key things about this class of drugs, they cause respiratory depression and sedation. So I do not prescribe benzodiazepines to patients who engage in substance use, alcohol, drug use, and I will educate them. I said, you're already engaging in an activity that causes respiratory depression. I will not prescribe a medication that will further suppress your respiratory system, because what could happen? Death. So you have to educate your patients. You have to educate your patients too that these are drugs that can be addictive. And as a result, they can't just stop taking them. Yes, and that they can't just stop taking them. So even sometimes patients will come to me on very high doses of benzos, which I am all willing to prescribe. I can't just say, oh no, I'm not prescribing this much benzo for you. I have to prescribe it and work with the patient with a plan as how we're going to take you off. And it's usually a slow, lengthy process because it is an addictive substance. The advantages, they're fast acting, useful as PRN. Disadvantages, as I mentioned, addiction, tolerance, withdrawal. And this is what I tell a lot of my patients. It can cause cognitive impairment, cognitive dulling. When they start telling me, oh, I can't remember things or have a hard time, maybe we should take away the benzo. And for those patients who can have good insight and who can reason through effectively, they will say, you know what, Zoe, I remember you mentioned to me that it can cause cognitive issues, and I've noticed that I'm not as sharp as I used to be after how many years of use or whatever. And they will ask to be off this med. They'll ask to be weaned off. But for the larger majority, this is like pulling teeth trying to get them off this drug or trying to tell them that it is not safe practice or appropriate practice to use this long term. The elderly, it can cause falls. Very often I have elderly patients who are taking it and they tell me, oh, I slipped or I stumbled, and I immediately say, you know what, let's get you off these benzos. And teeth and nail again, they're going to fight, they're going to push back, because if they've ever missed a dose of benzo or not had the benzo for a week, they know how it feels to be like revved up and really anxious. And I'm trying to explain to them that it's not so much the anxiety you're experiencing, but what? What do you think they're experiencing when they're without it?
Withdrawal.
Yes, withdrawal symptoms. And now you have to educate them about this. You want to educate them to avoid alcohol use because, as I mentioned, it's another depressant. Make sure they're hydrating. Educate them about it affecting their liver and their kidneys. So education is key. Sometimes patients will come to me and they will hear that their grandmother, auntie, uncle, cousin, niece is taking Klonopin and it works, and they'll come to me asking for Klonopin. And sometimes after educating them about the class of drugs, the side effects, the addictive properties, they'll be like, oh no, don't give me that. I don't want it. So sometimes education proves to go a long way. Some withdrawal signs, from the benzos, they can have convulsions, a depressed mood, vomiting, sweating, can't sleep, muscular cramps. So imagine after they miss their benzo and they start having these feelings. Of course, they're going to want their benzo. It's the only thing that works. You have to educate them about withdrawal syndrome as well. Other anxiolytics is Buspar. So these are drugs that you will see prescribed, not so much PRN. Well, hydroxyzine is prescribed PRN. I usually prescribe it for anxiety and for sleep. You have Tenix, Paxil, Effexor. Those are the ones that are not PRN. The only one here that's usually prescribed PRN is the hydroxyzine. These other ones are prescribed more long term to treat the anxious symptoms. Clonidine, guanfacine, propranolol, and so, some of these that are prescribed for anxiety on this list are not FDA indicated for anxiety, but they're prescribed off-label for such. The antidepressants that I mentioned, the SSRIs, the Prozac, Paxil, Lexapro, Celexa, Zoloft, even though it says antidepressants, just remember, they not just treat anxiety, they not just treat depression, they treat anxiety, they treat tic disorders, they treat PTSD, so they treat a wide array of different illnesses, of different disorders. Advantages, as is listed here, they treat many disorders. Disadvantages, weight gain. Patients, and I've had this happen quite a few times, they complain of a decreased libido. It may cause a neuroleptic malignant syndrome, and we discussed this in the last class, I believe. Does anybody remember medical mnemonic for neuroleptic malignant syndrome? It was hot, stiff, and out of it. This is the patient who has muscle rigidity, increased body temperature, stupor, or in a coma. So SSRI use can cause a neuroleptic malignant syndrome. You should definitely familiarize yourself with that term. Or they can have a serotonin syndrome. And we went over this in our last class as well. You should familiarize yourself with both those terms. Any questions about tonight's material? Ida did a very good job talking about everything as I went on. So do most patients expect SSRIs to work right away? Yes, they do. And you have to educate them that it takes a good 3 to 4 weeks before they can get full effects. And this is why they'll probably have like a benzo, like a three-week supply or something to get them over that initial, so they can function and cope until the SSRI takes full effect. Very often too, you'll see patients coming out of the hospitals on these SSRIs. That's after being inpatient for some time and having started this drug and being in the acute care setting where they take something more PRN and short term. But yes, they do expect that it's a magic pill And this is why I try to educate patients. There is no magic pill. There's no pill that's going to take away your anxiety or take away your depression. They have to engage in those non-pharmacological methods, such as the therapy and those things that is necessary. So there is one thing that I usually do. Where is it? How do I share my screen here? Any other questions? No. Share content. How do I share my screen? There's no option that says share screen. Does anyone know how to share your screen? I've done it before. I usually do a Kahoots game, and it kind of just takes the little things that we learn and put it like in a game format, like you go through it as a group. For some reason,
If you go where the chat, yeah, the arrows at the bottom, the chat.
yeah, I press that one and I see.
Yeah,
share.
and there's a on the bottom. There's a chat bubble. There's the two people, and then there's like a box with an arrow, and that one is the share.
Let me see. Share application screen. Okay, there we go. And share. Share entire screen, application window, share entire screen. You guys see my screen? It's Kahoot. I can't see what you're saying. Let me see. Is that a yes?
No, we can't
No.
hear you.
No. So I'm gonna have to ask Pam how to do this because let me see, share. How about now?
No.
Oh man. I don't want to share my camera. I don't want to share my files. I want to share my screen. So it's a share application / screens. And then I click and share. And I hit share, but it still won't show. No? Share your screen. I want to share contents of your screen, your entire screen. I chose that and I hit share. What are you guys seeing?
Just your face.
Okay, so I'm gonna have to touch base with Pam because this is how I usually do it. I go in here and I choose share application screen. Let's see, share files. Nope, that's not what I want. I want to share my screen. Okay, so we're gonna have to do this on Wednesday, and I'll reach out to Pam before that so we can make sure you do some Kahoots. Because other people in the previous classes have all said this was one of their favorite things about this class because they learned a lot from doing the Kahoots games. Okay. Any questions? Anything else you guys would like to discuss tonight? Is that a no? Okay, so we will end here tonight then. And we will definitely have time on Wednesday to do some Kahoots after. So I will reach out to Pam to figure out how I can share this screen with you guys. It was nice talking to you guys tonight, and I'll see you on Wednesday.
Thanks. Good night.
Guys, take care.